For those of you who don't know us, we're the Long-Term Care Community Coalition. We are a nonprofit, nonpartisan organization entirely dedicated to improving care and quality of life for residents in long-term care facilities, particularly nursing homes and assisted living. Our work, it focuses on policy research and analysis, and we use that as a basis for systems advocacy. But over the last dozen years or so, we've been doing more and more public education. And I would just say that was really in recognition that it's very hard to move the ball. It's very hard to get nursing homes to change systemically. But with that being the case, we wanted to provide residents, families, long-term care ombudsmen, others who are working with residents and families with the tools that they can use to advocate for better care for their residents and for better care for the facilities in their communities. Lastly, we're also the proud home to 2 local long-term care ombudsman programs in our home state of New York. Today's webinar is called Building the Backbone, How Stronger State CNA Requirements, Training Requirements, Certification Requirements Can Lead to Better Nursing Home Care. The materials from today's webinar available on our website, and the recording will be available on the website as well, also on our YouTube channel by the end of the week. A quick outline of today's program. I'm going to first talk about what the CNA does, the role of the CNA, and why these training and competency requirements are important for us as advocates and as consumers to know. The next part, we're going to, Adriana, will be reporting on our new report and the web resources on state CNA certified nurse aid training requirements. Part 3, we'll discuss data and resources to support resident-centered advocacy. And lastly, we're going to talk a little bit about current staffing priorities. We're talking about staffing advocacy priorities there. So part 1, the role of the CNA. So here we have the Code of Federal Regulations, 42 CFR. And this speaks to the requirement that facilities have sufficient nursing staff with the appropriate competencies and skills to provide nursing and other services to residents to ensure that every resident is able to live safely and to attain his or her highest practicable physical, mental, and psychosocial well-being. And that includes, of course, living with dignity. That's important for any human being and is part of their mental and psychosocial well-being. So that is just really important, and I think a really important predicate to everything that we talk about when it comes to nursing, and especially nursing homes, and especially when it comes to staffing. Under the federal rules, there are essentially 3 categories of nursing staff, going from registered nurses to licensed practical nurses or licensed vocational nurses. Those are essentially the same type of nurse. It varies in name by what state you're in. I generally refer to them as licensed practical nurses, or LPNs, and that's how we will refer to them, in today's program as LPNs generally. And then we have certified nurse aides, CNAs, which is the heart of what we're going to be talking about today. A little bit about the roles of these staff. RNs are the highest level of profession, highest level of training and of licensure that are generally providing care in nursing homes. They're in charge of monitoring each resident's general health, organizing, overseeing the care that's going on in the facility, including the care that's provided by the LPNs and the CNAs. Now, the LPNs and the LVNs, they provide basic medical services. They can change bandages, check blood pressure, insert catheters, et cetera, some of the examples that we put here. And lastly, but in many ways, most importantly, certified nurse aides, they help residents with their activities of daily living. This includes feeding, bathing, dressing residents, helping residents to ambulate, to get around the nursing home, to get to the bathroom, to get to the dining room, et cetera. They help residents with hygiene, personal care activities, washing hair, basic grooming, washing hands, et cetera. They also are on the front lines, really, of observing what is going on with the resident, and if there are any issues with the resident's health, if there's a change in the resident's health, if there is a change in how the resident is functioning or responding to people eating, for instance, if their eating habits change, if they seem depressed or non-responsive to, unwilling to talk, maybe if their habits have changed, that it's their responsibility to report that to licensed nurses. So a couple of things before I pass it over to Adriana. I want to know, why are we doing this program and why did we put together these materials? Besides having a record and an accessible record, I should say, of what each state requires for CNAs, which is of course valuable, I think, in and of itself, is we wanted to do this program about the report and help the people that we work with, you all, our audience today, to understand why this information is useful and important. And number one is, this kind of reiterates what the first slide was talking about. Everyone who provides care and services to residents is required to have the competencies necessary to provide safe, appropriate, and dignified care to each resident based upon his or her needs, his or her goals, etc. CNAs provide the vast majority, 90% approximately, of resident care and services. Therefore, it's really important that CNAs are both equipped, have the knowledge, the skills, etc., and are enabled, are supported to provide these care and services to the residents. Now, I know that when I first started doing programs with families, with family councils, and that a lot of them would, I would talk about some of these residents' rights, and people didn't really understand. They would become angry and upset, and rightfully so, because they were not seeing that these rights, that these standards were being implemented in the lives of the residents, of the people that they loved who were in the nursing home. And I understand that I've had family members in nursing homes over the years. I have a family member, in a nursing home right now, and it is very frustrating. And this gets back to, why do we talk about it? Why is it important to get it out there? Why is it important for people, residents and families and those who work with them to know about this? Is because our feeling is, unless you know what your rights are, unless you know what you have a right to expect, you will not get it, or very unlikely to get it. Yes, it's absolutely challenging. I understand that. I've lived with that. It's very, very challenging to get these rights implemented in the lives of our residents. But it's our belief that having the knowledge, having the tools and the resources to use that knowledge can be an important and valuable stepping stone to getting that underway. The second, important thing I think from our perspective, and why why this is important information to have and how it can be useful, is that as a result of widespread and persistent understaffing, not just since COVID, but for years and years and years and decades in communities throughout our state, throughout the country, understaffing is a persistent and too often a really terrible problem. And given that situation, not every nursing home, but far, far too many of them, knowing what CNAs can and cannot do, including what's their expected skills and competencies, which is what Adriana will be talking about today, can help support our advocacy at both the resident level and the systemic level. And I give two examples here. One is that knowing that a CNA is required, for example, to have annual training on dementia care can be helpful when you're advocating for appropriate dementia care for your resident. It's not a fantasy. It's not something that you are hoping for or wishing for. It is an expectation that the nursing home and the staff that they employ are going to have that knowledge. Secondly, in terms of a more systemic example, is that knowing that another state has higher curriculum requirements can be helpful in advocating for improving CNA training requirements in your own state. And as Adriana will talk about, there is a wide variety of training requirements. So I'm going to pass this on now to Adriana. We were very fortunate to have her last year, and she came back to do this presentation. She is a law student at Yale University, and prior to that, she actually worked for the New York State Attorney General's office in the Medicaid Fraud Control Unit, who presented for us last month. And as I mentioned earlier, were really excellent. So without further ado, Adriana, I'm going to hand it to you.
Thank you so much, Richard. It's so great to be here with you all today. As Richard mentioned, I'm a second-year law student, and I got connected with you all when I was in an Aging in the Law seminar last year. So I did work at the New York State AG's office in their Medicaid fraud control unit, and we handled some of their nursing home patient abuse and neglect cases. So it's really good to be here with you all and sort of to dig into these requirements that we looked at. So we basically looked at kind of a swath of requirements for CNAs. And by way of background, when an individual is applying and would like to be a CNA, they have to complete a training program, and then they have to take a certification exam. And when they pass that exam, then they'll be certified as a CNA. And going forward, they do have yearly requirements for how to maintain their license. So what we looked at in this report was sort of those two aspects. First, what are the requirements for the training program itself? So we looked at training hours and then curriculum requirements. So what do these programs actually need to be covering? And then we looked at, okay, once a person is certified, what are the renewal requirements and what are their in-service requirements, which are basically continuing education requirements. So some of the challenges of this is that there are both federal level requirements and state level requirements. So the federal requirements sort of set the floor and the minimum, and then states can deviate from that if they go above and beyond those requirements. That being said, at the state level, these sort of four aspects that we were looking at are not centrally located. So sometimes the requirements are in the state statutes, sometimes they're in the regulations, and then sometimes they're in guidance documents, which are sort of binding documents that are issued by maybe a Department of Health or something like that. And then one thing to note is that these programs, the training programs for CNAs, are often administered by the facilities where the CNA is going to work. So maybe it's a nursing home, they're going to be running that program for the CNA. There are some colleges or universities that might have a CNA program, perhaps as part of their RN or nursing school. So people might be able to be certified that way as well, but it's mostly through facilities. So this is just background. Again, they're the primary caregivers in the US. One thing to note as well is that during the pandemic, the Centers for Medicaid and Medicare Services actually waived a lot of these training requirements. So the requirements that we'll talk about today were not necessarily the ones that were in place in states during the pandemic. And this report is actually updating a 2004 report that I believe Richard put together. So now I think we'll dive in. We do have a bit of a pop quiz for you all. And I would love to know, how many hours of training do you all think that CNAs are required to complete for certification? So I believe Eric just sent out a poll that should have popped up. And I will give everyone a minute to fill that out. Okay, let's see. Eric, do you have the results?
We're still getting there. Answers are pouring in. We'll give it 20 seconds until pencils down.
Perfect.
And I will share the results then.
While we're waiting for that, I'll just mention, Adriana, thank you for mentioning it, that many of the training requirements were waived during the pandemic. Those waivers just ended and will be, so all facilities will have to get up to ensuring that their CNAs are trained, but that was something of great concern to us. The provider industry has pushed for years to decrease training standards, and they did so during the COVID pandemic. And from our perspective at LTCCC, we understand how it made sense to try to get bodies on the floor, but from our perspective, when nursing home residents most needed competent and qualified staff, CMS had actually lowered and decreased the staffing requirements for CNAs. So thanks for mentioning that.
Thanks for sharing. All right, so the results are in, and here's what we got. We have, I'm going to end the poll. We have 2% of this audience said 0 hours of training are required for CNA certification. 36% said 16 hours are required. 44% said 75 hours are required, and 18% said it depends. So what do we do with that, Adriana?
Very good. It was a little bit of a trick question. The answer is it depends. But that being said, as we'll see, the federal minimum requirements are 75 hours. So I think just on the next slide, we'll see some of those federal requirements. So there are 75 hours of training required, and that is going to include both hands-on training or clinical training, and then also more classroom hours. And that training is required to cover specific curriculum. There is also 12 hours of annual in-service or continuing education requirements for people once they are certified as a CNA, and they must have worked in the past 24 months to maintain certification. So at the federal level, there's not an hours requirement. Presumably you could have worked 1 hour that was paid as a CNA, but you do need to have that work. And then just to talk about the federal curriculum requirements, I know the font is a little small here, but you're required to have 16 hours of training in the following 5 subjects before you can have any direct patient or resident care. So those are communication and interpersonal skills, infection control, safety and emergency procedures, promoting residents' independence, and then respecting residents' rights. So after 16 hours of training in that, you can work on direct contact with the resident, and then the rest of the curriculum needs to include the following 6 subjects. So I'll go through them and also give an example. So first, basic nursing skills. That's going to include taking vitals, personal care skills. That will be grooming, bathing, then mental health and social service needs. That might be training about how to help a resident's emotional support, use their family as emotional support, care of cognitively impaired residents. So this is similar to what Richard was saying earlier about training in dementia or Alzheimer's. Basic restorative services, that's maybe once a resident is preparing to leave a nursing home, helping them ambulate, helping them understand how they can take care of themselves. And then lastly, training in residents' rights. So a curriculum program is required to cover all of these. However, states can differ from that as long as they meet all of those requirements. So here we've just highlighted a few key differences among states. So 21 states do not differ from the 75 hours. So they stay at that. The rest of the states do exceed 75 hours, but no state goes above 180 hours. So that's the max amount of training time for CNA programs. To give you a sense, this will take between 2 weeks at the low end and 6 weeks at that 180 hours mark. For in-service requirements, the most states require is 24 hours of in-service training per year. And for renewal, that hours, the amount of time they have to have worked as a CNA to maintain certification, most states set that around 8 hours. So you need to have 8 hours of paid work as a CNA in the past year in order to maintain your certification. For curriculum, this is a place where you saw states differ the most. Most states include training on religion, spirituality, and cultural competency. Some states, like New York, I believe, also include training on sexuality and gender in older adults. And then there are 1 or 2 states that have program requirements for caregiver, self-care, and stress management. So not only is this training focused on how to care for residents, but also how can these CNAs care for themselves. Lastly, something that we looked at where it was sort of accessible was screening or eligibility requirements. So for example, this is if a state has a minimum age requirement, like in New York, you have to be 17 years old to take a CNA exam, or perhaps it's an education requirement. So some states require an 8th grade education, some states require a GED in order to become a CNA. The reason why we don't have this information for all of the states is, as I mentioned earlier, these requirements are sometimes spread across a lot of different areas and documents. So we didn't go searching for these requirements for every state, but where they were in the regulations that we were already looking at, we did include them. And then lastly, we have your testing requirements. So as I mentioned before, CNAs will do their training and then they will take an exam. And the federal government requires that CNAs are allowed to retake this exam twice. And some states will have different amounts of times that a CNA can retake it, maybe 3 times. So that is a broad overview. And now we're going to dig into using the report, which Eric and the rest of the team have put into this amazing website. So really the goal for this report was to make it useful for you all, for policymakers, for advocates, for people who might want to be CNAs or have family and want to understand what these training requirements are in their state. So the report, as I'll show in a minute, it provides comparisons across states. It also provides comparisons from the state and federal level, and then it'll give you some in-depth analysis on every individual state. And that includes giving you links to the statutes, regulation, and guidance documents that we pulled this information from. So if you wanted to go directly to the source, there's going to be a link for you to be able to do that. So right now, I'm going to go through the website and go through a New York example. So I will share my screen. Let's see if I can do this well. Give me 1 second. Okay. Here we are. I hope everyone can see this. All right.
Yes, yeah.
Great. Okay. So Eric, I believe, will be distributing this link to you all. So you will have it, and we'll also have it on the website. But this is the CNA guide webpage. So from here, you'll be able to navigate to a bunch of different areas. So first, we have, if you wanted to look at the full report and download the entire thing, you could click right here to download full report. And as you can see, it's quite lengthy. It's 152 pages, but it is equipped with links within it. So if you come down to this second page, you'll see a table of contents. And this first part will have some discussion and the executive summary of what these requirements are, very similar to what we talked about today. But you'll also be able to see every state here and a breakdown of the requirements. So we've broken it into certification requirements, training program requirements, that's going to be the curriculum, and then the statutes, regulations, and guidance. So say you wanted to go to California and see their certification requirements, you could just click right here and it'll bring you straight to that. So you can see these eligibility requirements, renewal and in-service requirements, and so on. So that's how you can use this. You're welcome to download it, print it out. But if you'd prefer to just use the web page, I'm going to take us back to that home page. And you can see here that if you wanted to just look at the federal CNA requirements, you could click here. This is going to have the same information that we talked about, minimum hours, sort of those 6 basic curriculum, and then some more in-depth. You can see that that curriculum does go a little bit more in-depth. So I'll just scroll up. I'm going to bring us back to the homepage again. One last thing before we dig into the New York example is the state versus federal requirements. So if you wanted to search across states and say you wanted to see all of the states where the training hours differed from the federal requirements, you could click right on this. So total training hours, if you clicked that, it will sort the states into no, this doesn't differ from the federal. And if you keep scrolling, all the yeses are going to be at the bottom. So yes, it does differ. So you can do that for any of these topics, curriculum, in-service, or renewal work hours. So now I will take us, and I'm going to go through 2 states, one that has quite a bit of requirements and one that has fewer, just so you can get a sense of how that looks on this page. So again, we're just back at this home page, and there are 2 ways to navigate to a specific state. So you can use this sidebar here and scroll until you find your state and then just click on it. Or what I like to do is highlight the state right here. So we're going to go with New York, and you can just click the state right there. So now it'll bring you to a page that is just New York requirements. And we've have it broken down into 3 separate sections. So this first certification requirements is as if somebody were going to be a CNA and they wanted to know what they needed to do. So you see there's some criminal background check requirements, age requirements, and then it'll tell you a little bit more about the testing and then the renewal and in-service. If you wanted to look at the training program itself and the curriculum and hours, you would click on this second tab and it'll take you right to the hours. And as you can see, New York's curriculum is quite in depth. There's a lot of specific topics that need to be covered. I won't go through all of it, but you're more than welcome to. And then lastly, this is just the link to the statutes, regulations, and guidance. So if you wanted to see where we got the information from, you could come right here and click on these individual links. So the last thing we'll do here is just give you an example of a state that has fewer. I'm going to pick on North Dakota. So we'll come right here, click that, and then you'll see that North Dakota's, there we go. Their training program requirements don't differ from the federal level. So they just have the 75 hours and then their curriculum is the same as the federal. So that's just to give you a sense of what this looks like and how you can use this. So I'll come back to this main page. And I will stop sharing my screen now. There we go. The one last thing that we wanted to go over. Also, I should mention that we do have in these slides, we sort of have a step-by-step. If I went too quickly, or if you wanted to come back and reference that, these slides will be on the website and you'll be able to kind of go step by step through and see how I navigated to certain places. So that is all on the website for you. But lastly, before we send it back to Richard, I wanted to kind of zoom out and give everyone an idea of what the international comparisons look like. We looked at a few European countries, and these are mostly taken from another report. But as you can see, the CNA equivalent in other countries have far more training required of them in terms of hours. So one thing to note is that sometimes CNA equivalents, it's sort of hard to understand what that term is in another country. So you'll notice that on this slide, there's a little asterisk and it says that these personnel appear to be more like LPNs, which have a little bit more training as Richard mentioned in the US. But even still, the least amount of hours required here, or the least amount of time, is 8 months. So in other countries, the CNA equivalents have 8 months of training as compared to the 2 to 6 weeks that the US has. So while the curriculum does appear to be pretty similar in terms of what people are being trained on, they just have far more training. You can see Italy has 1,000 hours of training versus 75 at the federal level in the US. So I think that's one of the main takeaways that I had from this research. There are definitely countries that have fewer requirements or they don't certify nurse aides at all. But I think one of the takeaways that I had was just that the US requirements are low compared to other European countries. And then just the last slide that I have, I think, Richard, there we go. Okay, so again, comparatively, the training requirements are not stringent. Where the requirements are located matters, especially for advocates or policymakers. If something is located in the statutes, that's going to be harder to change than if it were located in guidance documents. And regs are somewhat in between. They're probably maybe almost just as hard to change as statutes might be. But that being said, I did find that there was room for creativity in the curriculum, and that was something that was exciting to me, is seeing how states have changed and changed the curriculum from the federal level and included things like cultural competency training and caregiver self-care training. So I thought those were exciting developments and places where maybe policymakers and advocates could have some flexibility. So I'm really happy to answer any questions later on, and I will send it back to Richard. Thank you.
Adriana, thanks so much. It's so interesting. And of course, I've read this a number of times. So I still thought it was really interesting. And thank you, everyone who's given feedback in the chat. We really appreciate it. One thing before we move on, I had a few slides I wanted to talk about, but I think it's also worth noting that when in doing this project and in doing the report that we did in 2004, we did notice that a lot of the actual providers of training do take many more hours than the minimum 75 or even the state minimum. So we saw, especially as I recall, the trainings that were provided by unions and by the American Red Cross tended to be much higher. And a lot of nursing homes, as many of you may know, a lot of nursing homes provide their own training, and we don't know the extent to which, obviously they have to meet these requirements that Adriana has been talking about, but we don't know the extent to which they go beyond. But I remember seeing some of the private training requirements, private training curriculum, were much higher, even over several hundred hours. I think I saw one that was over 1,000 hours. So I want to talk a little bit about some of the data and resources that can be used to support resident-centered advocacy. They fit in more with the staffing and with the original issue that I talked about of how can we use our knowledge to better advocate for people about whom we're concerned, both on the individual level as well as the facility level and on the systems level. So going back to our website, nursinghome411.org, I'm going to talk pretty fast because I want to go through several slides here. We have our Learning Center, which I hope many of you are familiar with. And that includes our webinar programs, our podcasts. Eric is our podcast host, and he is really excellent and interesting, so I highly recommend them. But we also have fact sheets. This is just a list of the fact sheets, and you can click on any of those. Any of our fact sheets, I should say all of our fact sheets, are very succinct and very short, and they explain the standard. They provide a citation to the standard. All but a few of them are 2 pages back and front, so easy to print out and use. But they go to, as you'll see here on the upper right-hand side, if you can, requirements for nursing home care staff, requirements for administration. On the left-hand side, you'll see requirements for dementia care. We have a number of dementia care fact sheets that can be useful to support this. And we always say, when we talk to residents and families and those working with them, is that using these or using any resource you have, it doesn't have to be ours, about a resident care standard, can start with talking to a CNA. So say, this is what I'm entitled to. This is what the dementia care standard is. How can we achieve this for my loved one? And as Adriana has been saying, that is already built in to the training requirements for CNAs. So very quickly, I'm going to go through a couple of these slides. This is our state page. It's a little bit different. We have a couple of pages, obviously, where you can find information for your particular state. This is general information, not the specific information that Adriana was talking about training, but here you can find information on staffing, on ratings, ombudsman resources, consumer groups if there are any, etc. Very quickly, every quarter, as I mentioned at the start, we put out a easy to use or fairly easy to use information on staffing for every single nursing home in the country. And as I said at the start, we found actually the very beginning of the program, before we got started, that we had found that the data show that the nursing home administrator staffing has gone down 20% since the COVID pandemic. And the administrator, of course, plays an important role, or is supposed to play an important role in ensuring the quality of care, the quality of staffing. They are where the buck stops, really, when it comes to a nursing home's care and safety and quality of life. Just one quick slide. I know it's a little bit difficult to see, but obviously on your own screen, when you download it, you can make it bigger. Here, I just picked New Jersey, which is where I live. So you can filter by states. I clicked on New Jersey, and you can see for each nursing home provider name on the first column, their city, the county, their resident census, and then the total nursing staff, their direct care nursing staff, RN staff, et cetera, et cetera. So we tried, again, there's a lot of data. What we tried to do is we try to make these files as usable. I know it can still be challenging, but as usable as possible. And we'll be doing more programs. The staffing is a huge issue always, but it's an especially big issue this year, as I'll talk about in a moment, with some of the developments going on, especially on the federal level. Very quickly, this is our Family and Ombudsman Resource Center. We have a variety of forms and tools for resident-centered advocacy, and we're working to expand this right now. Resident record-keeping forms, resident concern forms. We also have forms to help resident and family councils to help them develop and sustain themselves so that people can have some easy-to-use tools that they can use to, again, track what's going on with their resident, to know any concerns for care plan meetings, for speaking with CNAs, nursing or administrative staff, et cetera. I wanted to end with a few words on our staffing advocacy priorities. There's actually, I would say, never been in more time, certainly not since 1986, 87, when the nursing home reform law passed, but since that time, at least, there's never been a more important time to speak out, to raise all of our voices in regard to safe staffing. As I'm sure many of you, if not most of you know, a year ago, President Biden in the State of the Union speech promised that his administration will be setting federal minimum staffing standards to ensure resident safety and dignity. I just want to make a little delineation here, or clarification. Since the 1987 nursing home reform law, also known as over 87, nursing homes have been required, as I said at the very start in that slide about nursing staff, they're required to have sufficient staffing with the appropriate competencies to ensure that every single resident that they accept and retain in their facility receives the services that they need to attain and maintain their highest practicable well-being, clinical, social, psychological, et cetera. And we know, unfortunately, that too often that doesn't happen. And part of the reason for that, in short, is because a sufficient, quote unquote, sufficient staffing is not, can be subjective, excuse me. It's not always easy for a surveyor to hold nursing homes accountable. There's a lot of issues there, and we won't get into them today. But over the years, our studies and others have shown that surveyors are not inclined to be vigorously enforcing the safe staffing standard. So it's really important to have an actual number, a quantitative minimum staffing standard, and that's what the president has promised. So over the past year, the federal government has done a number of things. They have a request for information out that thousands of people, residents, family members, I'm sure some residents, organizations like ours and other organizations representing residents, as well as, of course, many nursing home providers all commented on. And then they're also doing other studies to try to find out, okay, what exactly is a minimum staffing number, set number? Hopefully that will include RNs as well as LPNs and CNAs. How much staffing is actually needed to ensure resident safety and resident dignity? So we're waiting to see that happen. Since the president made that announcement, however, the nursing home industry, has been working nonstop with millions upon millions upon millions of dollars of resources to fight any staffing standard whatsoever. They haven't even seen it. They don't know what it's supposed to be, what it's going to be, but they've been arguing the same old thing that they've been arguing since well before my time, since the 70s and since the 80s and 90s, 2000s, et cetera. Two or three things. One, the two main ones are, one, they can't find people to fill the positions. They're saying that now with COVID, but that has been their false argument, frankly, for many, many decades. If you read congressional testimony from the 80s, you'll see the same thing. Oh, we just are not able to find people to work in a nursing home. The second big argument they make is that they don't get enough money to hire more people to provide safe staffing. And then we also hear, I've read a couple of things recently, say, oh, the numbers of nursing staff in a nursing home really don't matter. Well, we know that's not true. Again, study after study after study has consistently and persistently shown that the numbers of staff and ensuring that staff are competent are absolutely essential for resident safety as well as for safety of staff themselves. So I want to just quickly, and we've used these slides before, so pardon me if you've seen it, but it's just so important to remind myself and we want to remind everybody that nursing homes say they don't get enough money to provide better care. The fact is that most nursing homes in this country are run as for-profit companies, and the nursing homes are seen as attractive investments by very sophisticated, generally speaking, investors. We've seen a lot of private equity, real estate investment trusts, other very sophisticated entities, limited liability companies, et cetera, going into this industry. And too often, for a variety of reasons, there's a lack of transparency and accountability for where the money is going. A lot of nursing homes use related party transactions as a means to hide profits by siphoning money away from resident care. And that's something, again, I can't recommend more strongly seeing, if you can, downloading or viewing our last program in February, which included the New York State Attorney General talking about the investigations they did and what they found, the major operators, and how they were moving money, putting into upfront profits and away from resident care. So this is really a bogus argument. And whenever we've tried to push the industry, okay, let's have some accountability for where the money is actually going, nobody wants to do that. We've never been able to get from the industry a verified information on where the money is going and why this argument that they make is supposedly valid. Second is, the second myth is that nursing homes can't find enough people to provide care. And the fact of the matter is, and now we know this, we have, as I note in the first orange bullet point here, we know that staff turnover rates in nursing homes are over 50% a year. That is incredible. Of course, you cannot sustain a workforce if you have this constant turnover. If you have people coming in, but they're also coming out at almost the same rate. Many nursing homes have over 100% turnover in a year. It's a completely unstable environment for any kind of company, no matter one that's providing vulnerable 24-hour day care to vulnerable individuals. As I note in the second bullet, the CNA job is persistently one of the most dangerous in the United States because quite often of low staffing. A CNA who was supposed to be helping someone who was a two-person lift will sometimes do it on his or her own, and that will result in injury to both the resident as well as the CNA. It's a very high-pressure job. It's a very demeaning job at times because of all the pressure that's put on CNAs and on the nursing workforce, RNs, LPNs, and CNAs in our nursing homes. Again, that turnover rate, it's not that there aren't people out there, it's that we're taking them in, chewing them up, and spitting them out, and they don't want to come back into this nursing home job, because of these conditions. So I'm going to ask, just to end this, our program and our discussions today, so please join us in speaking out for safe staffing. It's really essential. As I said, there's never been a more important time than right now to counter the industry's argument. The industry is spending millions upon millions of dollars to get out its, I would say, bogus argument that it just can't hire more staff. Again, and now they're saying it's COVID, it's a COVID problem. It's not a COVID problem, it's a business model problem. And we have to change the business model of nursing homes. There's just no excuse for not providing sufficient staff who are competent to meet residents' needs and enable them to live safely and with dignity. So a few points here. One, you could speak out now. You can go to our website, nursinghope411.org/find-legislators. And you could look up using your zip code or address your federal legislators, make a phone call, and make a difference. You can speak out in the future. We're going to be doing an action alert as soon as the federal staffing proposals come out, if not sooner. So please be on the lookout for that. Please join our action alert list to join us with that. It's available on our website. And we also recommend that you join the Consumer Voices Dignity for All campaign. They're doing some really excellent programs. I put the full URL here. It's on the consumervoice.org, this website. And right now, I checked this morning, it's a banner running across. It's the first thing on the banner. Just lastly, safe and competent staffing. It's what we pay for. It's what every nursing home promises to provide, and it's what every individual deserves. There's just no excuses for anything less. Last couple of minutes before we turn it over to Q&A, we are doing a monthly family empowerment half hour. It's on our Facebook page, facebook.com/LTCCC. The next one is next Thursday, March 30th at noon Eastern time. Please register to join us on Zoom, or you can visit live stream on Facebook. Our next webinar is Tuesday, April 18th, again at 1 p.m. Eastern, and the topic is going to be really fascinating and really meaningful, I think. It's going to be on retaliation in nursing homes and the fear of retaliation in nursing home. And the speaker will be Professor Elan Caspi. Elan is doing some really remarkable research for us on this, and we've talked to him a number of times about how his research is going, and I have to say it's very moving and very concerning, and something which I think we should all be aware of. With that, I thank again Adriana for joining us today and for her terrific work. This is such a valuable resource to have, in the way that you and Eric and Haley put it together is really great. For materials from today's webinar, again, go to nursinghomes411.org/webinar-CNA-REQS requirements, REQS. The Family Empower Half Hour is on our Facebook page, facebook.com/LTCCC. There's the bit.ly link to register for April's webinar. And then for staffing quality enforcement data for every licensed U.S. nursing home, please visit us at nursinghome411.org/data. And with that, I'm going to open it up for Q&A. And again, please join us, nursinghome411.org/join for those updates and for alerts and for invitations to future programs. We don't sell your name. We don't sell our lists. We keep it confidential. So I hope you'll join us. And with that, I'm going to open it up to Q&A for Adriana and myself.
Great. Thanks. We got plenty of questions, so thanks to all. And just to remind, the slides and video of this program will be posted on our website, nursinghomes411.org. You'll get an email from, it'll say it's from Sarah Rosenberg in a couple of days with that link as well. But be on the lookout. But here, let's start with the questions. I know Sharon had a few, but first question is, how do we find out if when the CNAs have gone through all the training that they need?
I'm happy to talk about this, and I think there were a few questions about this. So a CNA won't be certified until they've gone through that required training program and passed an examination. That being said, because CNAs are certified at the state level as well, sometimes states have a nurse aid registry, or they have sort of another website where you can look up a provider's license or certification, and you might be able to do that with their name. Some states have that, some states don't.
Great. All right. So now here's a question from Mary. Does CMS place limitations on a provider's ability to conduct in-house CNA training programs based on yearly survey results?
So there can be limitations placed on a nursing home. I don't recall the exact protocols. It doesn't happen very often, but they can have limitations, based upon their survey results, meaning that they've been found to harm residents, et cetera. And it's a really good question and important issue, because, as I mentioned earlier, a lot of nursing homes do their own training for CNAs. But if you think about it, if a nursing home has problems providing care, should a facility that doesn't know how to provide care be doing training for new people, or should that come from the outside? And so I would argue that it's dangerous and inappropriate, and it leads to the risk of perpetuating poor care services if you have the people who are providing poor care providing training. And then the other quick issue there is that quite often, as we've said a number of times now, it really comes to the competencies is a huge issue, and the staffing numbers is a big issue. Those are the two big issues. And so if you don't have, and we know short staffing is a huge issue in the majority, frankly, of nursing homes in this country. They don't have enough staff to meet even the basic clinical needs of their residents, according to the 2001 landmark federal study. So if they don't have the ability to meet their residents' needs, not just in terms of training or processes, but also in terms of having people on the floor, how are you going to take people off the floor? How are you going to allow them to take people off the floor to do an in-service training? It should really come from the outside.
The only thing I'll add to that, which is a little bit separate, but I found interesting, is some states require that the CNA's in-service training is attached to their personal evaluation. So if the CNA was evaluated and, had some weaknesses in certain areas, the state requires that that CNA's in-service is tailored to the areas that they need to improve. So that's more of, if we're talking survey of the individual CNAs.
And that's just to quickly add to that, for the in-service as opposed to a certification training, and Adrienne is talking about the in-service training, that even if the state doesn't require that, that should always be happening. And that's really part of the federal guidance, says that nursing homes are supposed to have a quality assurance and performance quality assurance performance, I forget what the I stands for now, review that is ongoing with a team of people that are doing that, and that's what the feedback, that's what the training should involve, is the things that are not working in the facility, anything that's identified, whether in a survey, but also internally, it's quality assurance and performance improvement, pardon me. That should be ongoing, and that's really required to be ongoing. If I remember correctly, that was part of the 2016 requirements that came about under the Obama era and changes, and that's really important. So yes, it should be reflective, again, of what is going on and what the staffing needs are.
Thanks. There was a comment in the chat that I just want to share from Cindy. The lack of clinical training sites is a barrier to getting more CNAs. Richard or Adrienne, any comments on that?
I don't agree with that. I mean, the clinical training sites, it does vary certainly by state. It varies by area. They're more in obviously they're more in urban and suburban areas than they tend to be in rural areas. But as I mentioned, and as the data themselves show, this is not our opinion, but the data show this, is that nursing homes have enormous turnover, and nursing homes have a bad reputation to start with, for, I would say, as a whole, for very good reasons, of being unsafe and undignified places to work as well as to live. So it's really a matter of coming that if you were paying people a living wage, you would have the people that were coming in, and you would have the resources, you would have the companies that would be interested in training them. So I would disagree with that, frankly.
Thanks. Now, I think this might be for Adriana, but it could be for both. This is a question from Erica. Do CNAs receive higher wages in other countries?
This is a great question, and one I wish I had the answer to. I did not have the time, admittedly, to look into this. My intuition is probably, but I'm really not sure. And I would love to look into this more.
Thanks.
I have nothing to add to that.
Yeah. But yeah, you can, So you can probably gauge just based on salaries in other countries and in those type of roles, whether it's higher or lower than the US. But again, we don't have that specific information. Is this, so this is from an anonymous attendee. What is the trend nationally here in the US? I assume this is in terms of CNA requirements. Is it to require more hours? Are we seeing more requirements, less? Is this going in a certain direction, or has it just been steady?
Well, I would say, I mean, we didn't compare our 2004 study to this study to see if there were any major differences. As I mentioned a couple of minutes ago, the Obama administration did add training requirements, or did add that quality assurance performance improvement requirement that should feed into a regular in-service training. I believe that's also when the requirement for in-service training on dementia care, care of people with cognitive impairment went into effect. So, you know, we've seen some, but certainly not a lot and not enough. And on the federal level, you know, except for the things I just mentioned, there's been no changes to the actual curriculum requirements, which has been 75 hours for the past 30 plus years.
Thanks. A question from Marianne. Who teaches the CNA curriculum?
Yeah, I'm happy to take this. So again, there are federal and state requirements for the instructors. I have the federal requirements right here, and I can drop them in the chat if people are interested. But basically, it has to be a registered nurse. Or a licensed practical nurse, and they have to have a minimum of 2 years of nursing experience. And then 1 year of that has to have been in the provision of long-term care and facility services. In some facilities, you see the director of nursing, the DON, as the training instructor. That's at the federal level. Those are the requirements. And then sometimes the program can bring in sort of like, specialists to give supplemental trainings, but the training overall has to be by an RN or an LPN with that 2 years of experience at the federal level.
Great. Okay, and we're nearing 2 o'clock. We started a couple minutes late, so we'll do a couple more questions. This is from Kay. What type of nursing home facility in-service training and other training is offered to CNAs? I suspect it differs from state to state. Are internal trainings shared with other facilities in the state?
So I mean, the in-service training is really, now we're not talking about certification training, which is what Adriana focused on in her research, and which is, as she's saying, it's difficult to find. I know it was a lot of digging in some states, but it exists in those states. For the in-service training, as I understand it, that's really done internally. So, you know, and as I mentioned before, every facility now is supposed to have a QAPI, Quality Assurance and Performance Improvement Committee, that is on an ongoing basis identifying the needs for training, the needs for skill sets, et cetera, in the facility to meet those residents' needs, and providing in services to address those needs and any shortcomings that exist. And that could be with anyone. So as Adriana said, for a certification training, it's required to be a licensed nurse, but I've done in-service trainings over the years, not frequently, but a few times in nursing homes about residents' rights and other issues. So it could be much more open.
The only thing I'll add to that is in some states, I did notice that their in-service requirements now have a requirement for dementia training with that in-service, but not all states, just a few that I noticed.
Great.
Thank you.
Great. And this is from Gloria Murray from the LTCCC Family Empowerment Team. We've heard that CNAs aren't prepared for the job when they start to work in nursing homes, which causes more turnover. What can be done to prepare them for what they will face?
Well, I'll step in. I mean, I think there's a lot, and I actually think there's a lot that Gloria, who used to be an LPN and served for 7 years as a ombudsman director for our program in the Hudson Valley here in New York, that she would actually be a great person to come up with a plan on this. But I think that, you know, having the training, having the skills, really ensuring that someone knows what they need. As Adriana said, you know, some states are even requiring that there be training on caregiving, self-support and self-care. You know, so how can you be supported? But also, you know, this is, you know, part of the discussion we've had for many years now about how to improve nursing home staffing is, I think, having career ladders, having a more holistic approach to how we're looking at staff so that people could have maybe buddies I've heard of, or having mentors on the floor that can help them. But of course, all this requires having sufficient numbers of staff as well as having the training in place. And I think if you had the sufficient numbers, that would enable them to be better equipped and to be able to go to maybe start off with more supervision, and then to be able to go to people for help when they needed it rather than winging it. I mean, so many of the the problems we hear about in nursing homes are because essentially, someone just winged it. They did what they could because it was such a stressful situation with call bells ringing that weren't being answered, and people needing help, people in pain, people not being able to go to the bathroom, etc. That's when we saw we've seen problems, and those problems are very, very widespread, unfortunately. So I think changing that, again, as I mentioned at the end of the portion portion of the program that I did, is that we need to change the business model. The business model right now is cutting staffing to the bone and letting residents, too often letting residents suffer, and getting pressure sores, getting having unnecessary falls, getting drugs inappropriately, not getting food that is decent. So we change the culture, consistent assignment, better staffing, better training, et cetera. I think that would counter a lot of these problems.
Great. So I know there's a lot of questions we didn't get to. We appreciate you asking them and participating, but we gotta, it's 2:04. So Richard, I'm gonna have you close this out.
Great. Well, thank you everyone for joining us today. Adriana, thank you so much for your excellent work and for joining us again. Adriana finished up last semester with this project, so she came in and she joined us here in March, which we really appreciate. Wish you all the best, Adriana. And thank you, everyone. Hope to see you next month, excuse me. And please do sign up for our alerts. Please join with the Consumer Voices program that I mentioned before. We really need to speak out about these issues and support better staffing, both for residents and for the care staff themselves in our nursing homes, and the time to do it is now. So thank you.